Welcome to the funnel effect. This deep dive is based on the SCAI expert consensus statement on management of in-stent restenosis and stent thrombosis, which came out in the Journal of the Society for Cardiovascular Angiography and Interventions back in 2023. And the authors, it's really a who's who, a true international powerhouse guiding us on these tricky post-stenting issues. We've got Lloyd W. Klein, Sandeep Nathan, Akiko Mehara, John Messenger, Gary S. Mintz, Ziad Ali, Jennifer Reimer, Yadavtar Sandoval, Kareem Al-Azizi, Roxana Marin, Sunil V. Rao, and Amir Lutfi. Quite the team. So let's jump right into the core problem they're tackling here. Coronary stenting, it completely changed the game for treating blocked arteries, right? Incredible outcomes for so many people. But, and there's always a but, isn't there? If stenting is the hero, then stent failure is definitely its Achilles heel. It's its persistent problem. And we're zooming in today on the two big types of failure this SCAI consensus focuses on. In stent restenosis, ISR, that's the slow narrowing over time, and stent thrombosis, or ST, the really sudden catastrophic closure. Our mission really is to unpack SCAI's new approach. It's pragmatic, algorithmic, and the big shift. They're saying the old way, just looking at an angiogram, it's just not cutting it anymore. This whole statement really hinges on using high-definition imaging to figure out exactly why the stent failed, because that why tells you how to treat it properly. Okay, let's unpack this.
Yeah, and for you, the listener, the clinical weight of this is just immense. Stent failure isn't some rare side effect. It's common, it's costly. We're talking high rates of people coming back to the hospital and unfortunately increased risk of death, especially with stent thrombosis. That's a code red emergency right then and there. The whole philosophy behind this consensus is a fundamental shift. We're moving away from just treating the symptom, the blockage itself, to treating the precise cause, the etiology. And that means, essentially, mandatory use of high-res intracoronary imaging. We're talking IVUS, intravascular ultrasound, or OCT, optical coherence tomography. These tools need to guide pretty much every decision. And actually, before we even dig into the failures, we have to stress the biggest takeaway. The number one recommendation overall, it's prevention. SCAI strongly recommends image-guided stenting right from the get-go at the time of the initial procedure. Basically, they're saying, get that foundation solid the first time. Use imaging to make absolutely sure the stent is deployed perfectly. If you do that, you massively reduce the risk of these really complex failures down the road.
That focus on prevention really does set the stage. So let's start with the first major problem, the more chronic one. In-stent restenosis, ISR, the narrowing problem, so the definition. Angiographically, ISR means the vessel's narrowed again by more than 50% inside that stented area. But crucially, it's only clinically relevant if the patient actually feels it like recurrent angina, or if there's objective proof of ischemia, maybe an abnormal FFR, fractional flow reserve.
Right. And what often gets missed, I think, is just how big and serious this issue still is. We've had, 2 decades of amazing improvements, better stent designs, fancy drug coatings, improved polymers. But despite all that, ISR is still stubbornly common. The overall incidence is still kicking around 10%. Think about that 1 in 10 patients who gets a stent might face this. But here's the really alarming part, how it shows up. A full 25%, a quarter of ISR cases, don't just walk in with stable chest pain. No, they present as an acute heart attack, an MI. And when that happens, the 30-day mortality rate is it's shockingly high, somewhere between 10% and 25%. This complexity, this risk, it really underlines why finding the right mechanism and treatment is so critical.
Yeah, it's clearly not just a simple biological issue, is it? It feels like a system failure when you look at the risk factors they list. The source material breaks them down into 3 buckets. Patient factors, angiographic factors, things about the lesion itself, and procedural factors. It's like a perfect storm of contributing issues. Looking at the patient side, some numbers really jump out. The big one they mention is diabetes mellitus. So for someone without diabetes getting a modern second-gen drug-eluting stent, or DES, the ISR rate is maybe around 5.7%. But for a diabetic patient, that number jumps way up to 8.7%. Why the big difference with diabetes?
Well, diabetes brings this whole systemic issue to the table: inflammation, impaired vascular healing, that exaggerated healing response we see in restenosis. The smooth muscle cells growing too much gets amplified in a diabetic environment. The body seemed to see that stent as a constant irritant, not just an initial injury. So you get more aggressive scar tissue buildup, that neointimal proliferation. Other patient factors they highlight are things like renal insufficiency, which usually means a sicker patient overall, and also presenting with acute coronary syndrome, ACS. That ACS presentation suggests there's already an active inflamed state in the arteries when the first stent goes in. Oh, and the consensus also notes female gender as a statistical risk factor. That might be tied to generally smaller arteries, perhaps, or maybe hormonal effects on how the vessel wall reacts.
Okay, so beyond the patient themselves, there are the angiographic factors. These seem to be about lesions that are just tough nuts to crack mechanically.
Hmm.
We're talking long lesions, right? Defined as over 20 millimeters, small vessels, less than 3 millimeters usually. And then really resistant stuff like chronic total occlusion, CTOs, or arteries, just packed with severe calcification. But the factors that we as doctors actually have some control over are the procedural ones. And the statement is really blunt here. The number one primary mechanical cause of ISR is stent underexpansion.
It's exactly right. Stent under expansion basically means that metal scaffold, the stent itself, wasn't pushed out fully against the artery wall. Maybe the balloon used was too small. Maybe they didn't use enough pressure. Or maybe they hit a patch of calcium that was just like rock and wouldn't give way. And if that stent isn't fully open, well, the blood flow isn't smooth, the shear stress is all wrong, and the chance of that neo-intimal tissue growing back goes way up. The metal isn't properly opposed, it's causing more damage. It's just a bad setup. And another really key procedural point is this whole metal jacket idea. The consensus specifically warns about putting in multiple layers of stents, especially that third layer. They say it's, quote, almost always associated with underexpansion and should be avoided. Stacking layers like that creates this sort of impenetrable barrier. It makes it almost impossible to fix the expansion later, and it dramatically increases the risk of the ISR coming back, possibly becoming refractory.
And we shouldn't forget geographic miss either. That's where the stent doesn't quite cover the whole diseased part, right at the edges, leaving this little gap where scar tissue or even new plaque can grow and cause narrowing just outside the stent ends. These are subtle problems, aren't they? Impossible to reliably spot just with angiography. Okay, so we got the mechanical side, the stent isn't open properly, and then there's the biological reaction. Let's dig into the pathogenesis, the why behind that tissue regrowth.
Biologically, yeah, the earliest and still most common reason is what we call neo-intimal tissue proliferation, or hyperplasia.
Yeah.
You put a stent in, it causes some local injury to the vessel wall. It has to. And the body kicks off this exaggerated healing response. Smooth muscle cells start migrating and multiplying across the stent struts, trying to cover it up, repair the damage. But they often overdo it and end up filling the lumen, narrowing the artery again. But here's where things get really interesting and where time becomes critical. It leads us to this newer and frankly more worrying mechanism, neoatherosclerosis. This is being recognized more and more as a cause of late failure. We're not just talking scar tissue anymore. This is actual accumulation of lipid-filled macrophages, foam cells, and sometimes even necrotic cores forming inside that healed neointima. Basically, the body heals the stented area, but that new tissue itself becomes prone to developing fresh atherosclerosis. It starts looking like regular coronary artery disease all over again, but inside the stent.
Wow, that's genuinely fascinating. It implies that even if the initial stenting was perfect, deployment was spot on, healing was great, the patient could still face failure years down the line just because the inner lining of that stented segment developed a new problem.
Precisely. And this dual nature, early issues being mostly mechanical or hyperplastic versus these late failures often being neotherosclerotic. That's exactly why SCAI pushed back against the older, simpler ways of classifying ISR. They came up with this new system. It directly links the time frame to the likely underlying mechanism. It forces clinicians to think pathologically, not just about how many months have passed.
Let's go through that new classification system then, because it really feels like an intellectual core of this whole deep dive.
Absolutely. So the new SCAI classification breaks ISR down by time, linking it to the probable cause. Early ISR, that's less than 30 days. Almost always this points to a mechanical failure. The stent was undersized, it wasn't fully expanded, or there was an immediate procedural complication like a tear at the edge, an edge dissection, or maybe even a stent fracture. Patient comes back within weeks. You hunt for a physical problem first. Late ISR, between 30 days and 1 year. Okay, this is the classic window for that biological overreaction. We see delayed or maybe incomplete healing, sometimes related to the drug on the stent itself, mixed with that standard intimal hyperplasia, the scar tissue buildup. The drug's effect is waning, and the vessel's kind of trying to catch up on forming scar. Very late ISR, more than 1 year out. Now, this is the really crucial time frame for suspecting neotherosclerosis. Yes, hyperplasia can still happen, and you might see a late stent fracture occasionally, but the most common culprit this far out, it's the development of that new, potentially vulnerable plaque inside the old stent.
What's so striking there is how connecting the time directly to the likely mechanism just completely changes your clinical thinking, right? If a patient shows up with ISR 6 years after their stent, You shouldn't just think blockage. You should immediately suspect neotherosclerosis, which means your first thought isn't just open it up, it's manage this potentially unstable plaque. Maybe that means debulking before putting in anything new.
That's the whole point. That diagnosis dictates your tool choice. Do you need a different kind of balloon? Do you need atherectomy? Do you opt for a drug-coated balloon versus another drug-eluting stent? And the fundamental problem is angiography alone, that shadow picture, it just can't reliably tell the difference between dense, stable scar tissue and soft, lipid-rich, vulnerable neotherosclerotic plaque.
Which leads us perfectly into part 2, how we guide treatment for ISR. And the big headline here from the consensus is that angiography by itself is just, well, it's inadequate.
It really is the core message, yeah. Angiography shows you the lumen, the shadow, where blood isn't flowing well. But it doesn't show you the vessel wall itself. It doesn't reveal what that tissue blocking the stent is. Is it scar? Is it plaque? How much calcium is holding that stent collapsed? How many layers of metal are already in there? Angiography just doesn't have the resolution for that. Identifying the mechanism requires seeing the stent in the artery wall directly. IVUS and OCT aren't just nice to have here. The consensus positions them as essential diagnostic tools for ISR. It's about replacing guesswork with actual measurement.
Okay, so let's break down these imaging tools, IVUS versus OCT, and what the source says are their specific strengths. First up, IVUS intravascular ultrasound. Uses sound waves, gives you cross-sectional images. The consensus highlights it's excellent for seeing the overall plaque burden, figuring out the true vessel size by looking at the external elastic membrane, which helps size the stent correctly. And it's often preferred if the patient has kidney problems because it generally uses less contrast dye than OCT. It gives you that good, deep view into the vessel wall, lets you accurately measure stent size relative to the healthy parts of the artery.
Right. Then you have OCT optical coherence tomography. This uses near-infrared light, and because of that, the resolution is just stunningly better. We're talking nearly microscopic detail, about 10 times finer than IVUS. This makes OCT fantastic for spotting really subtle but critical things. Things like a ruptured thin cap on plaque, the specific look of thrombus, distinguishing red from white clot, pinpointing stent expansion issues, strut apposition, and maybe most importantly for those very late failures, identifying individual stent struts that haven't been covered by tissue yet. Those uncovered struts are highly thrombogenic. OCT does have limitations, though. It needs the blood cleared from the view, usually with a contrast or saline flush, which can be an issue sometimes. And its light doesn't penetrate as deeply as IVUS sound waves. So if you need to see deep into a really thick calcified wall, IVUS might be better. But if you need to count individual struts, check for tiny bits of thrombus, or confirm perfect apposition, OCT is superior.
And both tools give us clear goals for optimization, right? The consensus really hammers home that a suboptimal minimal stent area, or MSA, is the key predictor of failure. They set actual targets. Using IVUS, you want that MSA over 5.3 square millimeters. Using OCT, it should be over 4.5 square millimeters. Or, another way to look at it, the MSA should be more than 90% of the area of the healthy reference segment nearby. If you achieve those numbers, you know you've likely fixed the mechanical aspect.
And importantly, before jumping in to fix anything, SCAI says for intermediate ISR, where it looks maybe 50–70% blocked but the patient isn't acutely ill, you need physiological proof. You should demonstrate objective evidence of ischemia, usually with FFR. If that FFR is high, say above 0.80, it means the narrowing isn't significantly limiting blood flow. In those cases, repeating the intervention might not actually offer benefit over just continuing medical therapy. Some observational data suggest deferral has similar outcomes if the lesion isn't hemodynamically significant. The intervention needs to be clinically necessary.
Okay, so assuming the lesion is proven significant, then we move to the treatment algorithm laid out in the source. This is where the precise planning comes in. And the absolute critical principle, echoing that SCAI philosophy, is you must address and correct the original failure mechanism, especially if it was under expansion before you even think about putting another device in. This is all about avoiding that dreaded recurrence trap. ISR coming back once is already common, maybe 20% of the time. But here's that truly shocking figure we touched on earlier. The failure rate after putting in a second layer of DES, it jumps to a staggering 33% at 3 to 5 years.
Yeah, and it really makes you ask that question. Why do we keep layering stents if the failure rate gets so astronomically high after the second one? The problem is you're often building on a shaky foundation. If that first stent is squashed against rock-hard calcium and never fully opened, putting another stent inside it just crushes the metal further. It practically guarantees the new stent will also be underexpanded, and it just accelerates the return of restenosis, often making it even harder to treat next time. So the focus absolutely has to be fix the foundation first. If imaging shows underexpansion because of calcium, you have to tackle that calcium high-pressure balloons, maybe atherectomy, maybe lithotripsy, before you consider adding another drug delivery device.
All right, let's walk through the main treatment options guided by this imaging-first approach. First, there's repeat DES, drug-eluting stent. Historically, this was kind of the default, but the consensus really stresses this is only the way to go if imaging confirms the original stent is actually well expanded. If the first stent is open but failed because of too much biological tissue growth, then putting in a second DES, maybe even a different type, could be beneficial. There was a trial, RIBS third, that suggested you might get better results using a DES with a different drug than the one that failed the first time.
Then we have drug-coated balloons, DCBs. Now, these are seen as potentially game-changing because they deliver that anti-growth drug, the paclitaxel usually, directly to the tissue without leaving behind another layer of metal. Several trials have shown DCBs are non-inferior to putting in another DES for ISR, which is why in Europe they have a Class I indication for this. They're a standard tool.
Hold on. If the trial data shows DCBs work as well as DES, and they crucially help us avoid that debilitating metal jacket effect, especially avoiding a third layer, how does the SCAI paper handle the really awkward situation that they're still not approved for coronary use in the U.S.? It feels like a major paradox.
It is. It's a huge point of frustration for clinicians here. Absolutely. The consensus document basically just reports the facts. DCBs are a critical tool, supported by good evidence, but currently unavailable for treating coronary ISR in the United States. So doctors here are forced to rely on either putting in another DES or using more aggressive mechanical tools like atherectomy, in situations where a DCB might be the preferred, simpler, and less metallic option elsewhere in the world. It definitely forces workarounds. Now, if the underlying problem is mechanical, then balloon angioplasty is often the first step. But not just any balloon. You need high-pressure, non-compliant balloons. These are designed not to stretch much, so they deliver force directly to the blockage. They're especially useful for focal narrowings, or if underexpansion isn't due to really severe calcium. The source even specifically mentions super high-pressure balloons. These things can go up to insane pressures, 35, even 55 atmospheres, specifically designed to crack open severely underexpanded resistant stents.
Okay, but what about those really tough ISR cases, where even the super high-pressure balloons can't open it up, or there's just massive calcification, or huge amounts of neointimal tissue? Then we need the adjunct therapies. This is where atherectomy tools come into play. We're talking rotational atherectomy, RA, orbital atherectomy, OAS, or sometimes excimer laser, ELCA. Atherectomy is mostly considered when imaging clearly shows severe calcium is the culprit behind the underexpansion, like calcium ringing more than 270 degrees around the artery, or being thicker than about 0.67 millimeters. While these tools can shave away neointimal tissue too, it's important that trials using atherectomy by itself for ISR haven't generally panned out well. It's best seen as lesion preparation, debulking the blockage before you use a DES or maybe a DCB if available, or even just high-pressure ballooning.
And the newest player on this block is intravascular lithotripsy, IVL. This is really gaining traction, especially for heavily calcified neotherosclerosis, or those really stubbornly underexpanded stents. IVL uses focused ultrasound shockwaves, delivering pressures up to 50 atmospheres locally to actually fracture the calcium within the vessel wall. It does this without the risks of sending debris downstream, embolization, or potentially perforating the artery that can come with mechanical atherectomy. The source actually shows a great example figure where IVL succeeded in expanding a stent after even high-speed rotational atherectomy had failed. It suggests that for the really resistant calcium, sometimes only fracturing it will work. And finally, way down the list, reserved for truly refractory ISR, especially when you're dealing with multiple failed stent layers, is vascular brachytherapy, VBT. This delivers localized radiation to basically halt that excessive tissue growth. But its effectiveness really drops off the more layers of metal are present. The consensus notes that if you've got 3 or more failed layers, the chance of VBT failing within 3 years is over 50%. It's truly a last resort, which just underscores, again, why avoiding that third layer is so important.
So pulling this section together, treating ISR is like solving a diagnostic puzzle. The imaging tells you what failed and why, and that dictates your toolkit. Do you need to debulk with atherectomy or IVL? Do you need brute force expansion with super high pressure balloons? Or do you need a new drug delivery device like a DES or DCB? The image guides the strategy. Okay, now let's completely switch gears to the other major failure mode, the acute, life-threatening crisis of stent thrombosis, or ST.
Yeah, ST is fundamentally different. This is the sudden, abrupt clotting off of the stented artery. It almost always presents dramatically, usually as a big heart attack, an acute MI, or unstable angina, ACS. The stakes here are immediate, incredibly high. And while the overall incidence is lower than ISR, maybe 0.5% to 1.0% in the first year after stenting, the consequences are just devastating. Despite everything we can do now, the mortality rate observed when an ST event happens is still terrifyingly high. It hovers around 30%. This is an absolute emergency. Time is critical. And the risk isn't uniform. It's much higher for patients who got their stent during an ACS event initially, maybe 3.4% risk compared to those who had elective stenting for stable disease, where the risk is lower, maybe 0.3% to 0.5%.
And just like ISR, ST gets classified by timing using the Academic Research Consortium criteria. And again, that timestamp gives powerful clues about the likely cause. Right, so the classifications are acute ST within the first 24 hours, subacute ST from 24 hours up to 30 days, late ST between 30 days and 1 year, and very late ST happening more than a year later.
And if you map those timeframes onto the likely causes, you see really clear patterns emerging. Early ST, that's the acute and subacute phases, the single strongest predictor here is the patient stopping their dual antiplatelet therapy, their DAP, too soon. In that initial high-risk period right after the stent goes in, the blood is prone to clotting on that foreign material. Stopping the antiplatelet meds prematurely is often, frankly, catastrophic for the stent. But critically, early ST isn't just about meds. It's also heavily driven by those mechanical issues we talked about. Stent underexpansion, significant dissections at the stent edges that weren't tacked down, or geographic misleading disease segments exposed. Any of these procedural flaws can create areas of slow or turbulent blood flow, which is the perfect setup for a clot to form quickly.
Okay, then as we move further out in time into late and very late ST, the causes shift again.
Yeah.
Both mechanical and biological factors seem to play different roles here. Now we're often looking at problems with healing. Maybe impaired neo-intimal coverage, meaning parts of the stent struts remain exposed directly to the bloodstream for a long time. Those bare metal struts act like a scaffold, just waiting for platelets to stick. Malapposition, where the stent isn't quite flush against the wall later on, can also be a factor. And then, most ominously for very late ST, there's that recurring theme, neotherosclerosis, that new plaque building up inside the stent. The consensus cites this as the most common cause identified in very late ST cases. The same vulnerable, lipid-rich plaque that can cause chronic ISR can suddenly rupture years later, triggering a massive acute clot formation.
Absolutely. So when you look at the overall risk factors for ST, medication compliance is just paramount, especially early on. Stopping DAPT causes the majority of early cases. We used to worry a lot about patients being hyporesponders to drugs like clopidogrel, meaning the drug wasn't working well enough for them. Thankfully, the newer, more potent antiplatelets like prasugrel and ticagrelor seem to have reduced that problem of pharmacological failure significantly. But you still can't escape the mechanical side. Any situation that messes up smooth blood flow is dangerous for ST. Long stents, multiple overlapping stents, technically tricky procedures like stenting at a bifurcation. And yep, there it is again, the #1 mechanical enemy stent under expansion. That stent isn't perfectly round and open. It creates niches and areas of disturbed flow where thrombus loves to form.
So if ST happens or is suspected, how does SCAI recommend figuring out the underlying reason? Once again, it comes back to imaging, doesn't it? The consensus strongly recommends considering imaging immediately after you've managed the acute clot and restored blood flow.
Exactly. Just like with ISR, angiography alone can't give you the full picture when dealing with ST. IVUS and OCT are far superior for pinpointing the actual cause. Was it just one tiny uncovered strut? Was the stent actually underexpanded down to, say, 70% of the target size? Was there a clear rupture of neotherosclerotic plaque? You just can't see these critical details on an angiogram, but knowing them is vital for preventing the next ST event, and there's good evidence backing this up. Studies like ADAPT-US showed IVUS guidance significantly cut down definite or probable ST at 1 year. The ultimate trial also showed IVUS-guided PCI reduced targeted vessel failure overall. Using imaging to ensure optimization isn't just theory, it's probably the most powerful prevention tool we have against ST.
Which brings us neatly to Part 4, the actual management and prevention of ST. This seems to break down into 2 phases, handling the acute crisis and then the long-term strategy. Okay, so in the acute phase, it's an emergency. Emergent PCI is the standard of care. Get the patient to the cath lab, restore flow ASAP. The first step is usually simple balloon angioplasty. Just try to push the clot aside, open the vessel. Sometimes, if there's a massive amount of clot visible, adjunctive thrombus aspiration might be used to physically suck some of it out first.
And pharmacologically, you often need to hit the clotting cascade hard right away. The guidelines suggest strongly considering glycoprotein IB inhibitors in the acute setting. These powerful antiplatelet agents can help dissolve any clot that might have broken off and traveled downstream,
distal embolization and improve blood flow in the tiny microvessels. A really critical point during the procedure, though, is to try and limit putting in more stents. Avoid additional metal if you possibly can. Maybe reserve a new stent only if there's a big flow-limiting dissection after you've dealt with the clot. Why? Because the source is clear. The chance of ST happening again goes up with the total length of stent in the artery. If you can fix the underlying problem by just optimizing the existing stent, say, with a high-pressure balloon, after imaging confirms underexpansion was the cause, that's usually the much preferred long-term approach.
Right. So once the immediate fire is out, flow is restored, the patient is stabilized, then the crucial long-term prevention phase kicks in. And it all comes back to finding that root cause, the etiology. This means getting that IVUS or OCT done to really scrutinize the original device. Was it apposed correctly? Was it fully expanded? If that imaging reveals a mechanical flaw, like significant underexpansion, then you absolutely have to fix it. Using the same tools we discussed for ISR high-pressure ballooning, maybe IVL if there's calcification involved, to ensure the stent geometry is as perfect as possible for smooth long-term blood flow.
And finally, DDAP-T optimization. This is completely non-negotiable after an ST event. First step, check compliance. Was the patient actually taking their meds? If not, that needs serious counseling. But if they were compliant and still had an ST event, that strongly suggests the medication wasn't potent enough for them or there's some other biological reason. In that scenario, you almost always switch to a higher potency antiplatelet agent, usually prasugrel or ticagrelor, to get better platelet inhibition. And what about duration? Well, the newer generation DES have allowed for shorter DDIP durations compared to the old days, sometimes as brief as 1 month if the patient has a really high risk of bleeding. But after an ST event, that calculation changes. The decision to shorten or prolong DDP becomes an even more careful, individualized balancing act. You're weighing the very high risk of another ST event with its 30% mortality against the risk of causing a major bleed. It requires careful thought.
You know, this deep dive really brings the SCAI recommendations into sharp focus. The whole consensus feels like a unified strategy against stent failure, whether it's the slowdown of ISR or the explosion of ST, and they clearly identify a common enemy underlying both: suboptimal stent implantation, with underexpansion being public enemy number one.
Absolutely. The consensus fundamentally tries to lift the standard of care. It insists on using image guidance, IVUS or OCT, right from the start during the initial stenting procedure. The goal is to minimize that foundational mechanical failure from day one. The whole approach has to be proactive, not just reacting to problems later. And then, when failure does happen, imaging remains the cornerstone. It lets you move beyond just guessing based on when it occurred. Instead, you determine the precise mechanism. Is it mechanical underexpansion needing force? Is it late-stage neotherosclerosis needing debulking? The detailed picture from IDUS or OCT dictates the specific targeted intervention. You know, the old carpenter's adage really applies here. Measure twice, cut once, and maybe in cardiology it should be image every time.
That really sums it up well. Which brings us to a final thought, something for you, the learner, to maybe chew on, something that goes a bit beyond the pure technical details we've covered. We talked about how managing recurrent, really difficult ISR, especially when you're facing that metal jacket situation with multiple failed stent layers, often pushes clinicians towards considering coronary artery bypass surgery, CABG. This becomes particularly relevant with complex disease, like multivessel CAD or left main involvement. So considering that ultimate profound long-term risk that comes with repeated, sometimes ultimately futile catheter-based interventions, the real deep dive question might be this: how effective can a truly dedicated multidisciplinary heart team approach be in optimizing that very first stenting procedure, ensuring that minimal stent area goal is meticulously achieved every single time? Given that getting that foundation right seems to be our best defense against these incredibly complicated, life-threatening failures down the road, it's a challenging question about procedural discipline, teamwork, and focusing on the long game for the patient. Thank you for watching The Funnel Effect.